भारतीय पेशेंट.
कनेक्शन देगा भाई. वीडियो लेगा तुम लोग जाके. Good evening, everybody. Thank you, sir. Yes, sir. You are seeing the right thing. I am going to talk about THR for real India, real Bharatiya patients. Sir, every day, all of us are doing THR 1 or 2 per day. But are we thinking about real Indians? Are we meeting their demands? So after doing THR, are we allowing our patients to go to mandir, masjid, gurudwara, or having traditional Indian dinner, yoga, or Indian toilet? I think answer is no. So are we doing justice to our patients? Of course it is no. We do think, so we have to think out of box. Don't follow the footsteps of others which don't require this style of living. Allow your patients to sit cross-legged, hyperextend and hyperflex their hips. Now how to do it? The question is how to do it. For me, anterolateral approach is good. You can go through posterior approach also. 360 degree exposure is of acetabular as usual. Acetabular cup placement in 15-degree anteversion, no neutral or no retroversion. Cup inclination 45 degree or little bit more horizontal. Use minimum 2 screw to restrict any possible gliding of cup. Liner with posterior superior extra coverage, it is far beneficial. Femoral stem length should be according to the optimum soft tissue tensioning. Don't compromise on that. Tight repair of capsule and abductor is must. Your temptation should be to use larger head, if it is possible, 36. Post-op protocol, partial weight bearing after 2 weeks. Hip exercises, movement exercises, 3 weeks. Emphasis on hip abductor is very essential. After 6 weeks, aggressive hip movement should be encouraged, and your aim should be by 3 months, the patient should do all activity. Complications, of course. Dislocation is rare as it approaches anterolateral. Periprosthetic fracture, it occurs in very osteoporosis patient. See this grandma, 86 years, 4th surgery was there. It got fractured. Limb length discrepancy, very rare, as we are in lateral position, we can measure from opposite limb. Kinematics of THR inside body, doubt. We all have. Early we are liner or head wear and tear. During Indian toilet, the head articulates with the posterior inferior part of the cup. This part also have got the same thickness as other parts. So where is more wear and tear while squatting? If you are standing, your weight is maximum time on posterior superior part. This is not going to wear and tear. And you are allowing your patient to squat for half an hour or 2 hours. Is it going to more wear and tear? No, I think no. During class leg sitting, although hip is in 60-degree external rotation, but it is flexed. So there is no chance of dislocation. Maximum pressure on cup occurs while patient is sitting and getting up at 90 degree. We used to allow. During squatting, that pressure is not there. Kinematics of unilateral hinge, THR in situ, see. The patient is squatting, cross-leg sitting. How beautifully head is playing inside the cup. See how smoothly it is playing while sitting, cross-leg or squatting. Similar bilateral hip, same kinematics. Few cases, 35 years doctor, grade 4 OA, bilateral hip. See the movement. Again, ankylosing. Pain, 3 years, and 78-month post-op. See this lady. Again, 36 years female, bilateral. Don't hesitate in allowing your patient to have Indian style of living. Again, posterior dislocation fracture acetabulum. See, 35 years female, 7 centimeters shortening. In-laws rejected her for, she was at the birth of divorce because she was not doing to do any activity in her in-laws house. Head slit, there are 7 centimeters shortening. After THR, same lady, so happy at his in-laws house. This 16 years boy, again protegia stabili. Three-month fractured neck femur. Vakil Saab. Everyone, he has to sit, cross leg. Non-union neck femur. Posterior wall, repair and THR same sitting. Partial hip replacement, 18 years follow-up. See this grandma. Available literatures regarding Indian style of living, only one article at that too from Asian country, that is Thailand, is there. It is a retrospective study. In this case study, range of movement was proportional to the pre-existence of movement. Suppose patient was having full movement before surgery, he is going to have full movement. Many of the patients, despite of restriction of surgeons, they were doing full range of movement. Surgeon has not allowed to do full range, but they were doing. In my case, even bony and ankylosing patients were having full range of movement. So there is no question of pre-existence. Surgeons encourage every patient to have full range of movement. Take home message, tailor the coat as per body. Give what is asked for, not what you are having. To achieve this, keep the hip in anteversion, optimum soft tissue tensioning, and post-op follow-up. Check during surgery, after flexing 90 degree, whether hip is stable or not. Have faith and allow all activity to your patient. This will give you and your patient both very satisfaction. Thank you. 1 minute more. There is invitation for Nailscon Rajgir. So 1 minute more. Thank you.
Thank you, Dr. Sinha. Should we continue this session or because we are running late? So this is a time for case discussion. And our moderator, I request to all the moderator to come on the dais. Our moderator are Kapoorkar and
Suresh bhai.